Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse. I am Dr. Anthony Pellegrino from ChiroEdge, and welcome to this week's episode of the Chiropractic Research Breakdown, where each week we break down the most relevant chiropractic science and philosophy to empower you with the ammo and certainty necessary to change your community from the inside out. I am fired up to be with you guys today with Dr. David Russell from New Zealand. So that's not a New Jersey accent that you're going to hear coming from this guy. I am super excited because Dr. Dave is one of the, I would say probably one of the most published researchers out there today. You might be a little bit more humble than that, but every time I open up,
I think there's quite a few more.
I said one of, right? I mean, we've got Joel Alcantara, who just lives and breathes publishing. But every time I open up my computer and look at new articles, it's like your name is there. I've referenced some of your work in studies that I've published. So it's pretty cool to actually get on and chat with you today. So recently, this gentleman published a case report in the Annals of Vertebral Subluxation Research called Hemorrhagic Stroke, Improved Motor Function and Decreased Dyskinesis Following Chiropractic Care to Reduce Vertebral Subluxation, a case report and review of the literature. So we're going to spend some time talking about this case, just some time, because it is a case. I think there's a lot of value in it for us to understand clinically. But overall, what we're going to spend a lot of time talking about is the evidence surrounding subluxation and just giving you guys as much ammo and certainty as possible. I'm going to really spend the next half hour or so picking this guy's brain. So I hope that you guys enjoy that. So how's that intro, Dr. Russell? Good?
Brilliant.
Gosh,
I feel very, very special.
I don't often get brilliant.
Australian accent that you hear too here. I'm really weird. I'm an Aussie that lives in New Zealand. It's kind of like US American moving to Canada. It just doesn't happen that often.
Yeah, well, I'm glad that you did that. And you're also helping open or working with the Scotland College of Chiropractic as well, right?
Yeah, I sit on the board for the Scotland College of Chiropractic, which we're anticipating will open next year. But I'd encourage, if I can give a little plug to it, I'd encourage everybody to get online and go to scotlandcollegechiro.co.uk and have a little look, see what it's about. And if you feel you can support, please support, because there's only a handful of subluxation-focused chiropractic institutions around the world. And in the UK alone right now, there's about to be 3 other colleges open up that are not our necessarily subluxation, and then not subluxation-focused at all, actually. So at the moment, there's one. There's going to be 6 colleges there, and only one of those subluxation focused. So the Scottish College will be the second one and the first in Scotland.
That's awesome. That's cool.
Yeah.
Well, diving into this. So when the first 2 words of an article that are in a chiropractic journal are called hemorrhagic stroke, I'm sure many people out there wouldn't expect the next words to be about amazing results, right?
No, chiropractors caused it.
Yeah, I'm sure. It makes sense for me that you left Australia to go to New Zealand, though, knowing what's going on there. But yeah, so looking at this, I just kind of would love to just get just some basic case history, what you found, what was going on, what made you decide to take this patient or practice member on when, somebody else may have run out the door. Just kind of go through that information.
Well, the person came in to see me because they, had clearly lost motor function, and they wanted to see if that would improve. They'd been through months of rehab and really hadn't had any improvement. Primarily for them was their left hand strength, left upper extremity strength. And it was really affecting their quality of life, and being able to do daily activities, they required constant attention. And so, you don't take on cases. I mean, I've seen a lot of people that have had strokes, but you don't take on cases like that just without thought. And I think an important thing to mention is when you see someone, it doesn't matter who they are, but particularly someone with a serious issue like that, you have to be thoughtful and safe around it. So I did mind went back to being an intern again, neuro exams and doing the whole lot over and above what my normal assessment would be. And normal assessments, cerebellar function, which was fairly terrible in her case, range of motion, generic exam for subluxation, surface EMG and thermography, which I don't think I did in her case. And the important thing for me in terms of managing was being as precise, as limited or restricted as possible in how I adjusted her and the number of areas I adjusted. TRT was the technique I used in that case, which was pretty handy because, typically only adjust 1, 2 or 3 things anyway. But also it's light, precise, and the adjustments are in a neutral position. There's no rotation or anything like that. And I think that's important because you can get great results with someone who presents like that and still be as safe and specific as possible.
That's awesome. Yeah. And that's one of the things, as we kind of spoke about, I use torque release, not exclusively, but pretty dang close to exclusively in practice. And just kind of reading through this case, a lot of the different things that he did just make a lot of sense for me. With the evaluation, one of the things that I had mentioned that I found really fascinating, just speaking with you, that I actually got a lot from is we were speaking about anxiety, for example. And I mentioned that, I wanted to use something like the Beck Anxiety Inventory, which is awesome, but it asks really, really, really weird questions that you wouldn't want to give to like a 16-year-old. And you had mentioned something like the PHQ-4. And I looked at that and I'm actually going to start using that in practice. In this, you did a full functional independent measure, FIM, which is measures 13 motor, 5 cognitive items. It seems you mentioned you do a lot of different functional exams, a lot of outcome measures beyond that of just like a generic subluxation exam. Can you kind of give us a little more insight into like how you look at that and what makes you decide that, et cetera?
Well, typically in my practice, I always use a standard. Well, I use a health, wellness, and quality of life practice, health, wellness, and quality of life questionnaire with everyone, which is the blank study. Also ask, ranking 1 to 10. And this is a simple thing anyone can do in their practice. 1 to 10, how do you rate your physical health? 1 to 10, how do you rate your mental and emotional health? So that's built into our new patient paperwork. Then we ask that again at every progress. So it's a very simple. How do they feel about themselves? The same with the health, wellness, and quality of life. PHQ-4 didn't use it in that, but it is for anyone listening. If you see a lot of people, and there's a lot of people these days with anxiety and depression or concerns, that is it's 4 questions. And it's not to determine if they do or don't have. It's a screening test for anxiety and depression. But if it's positive, you might refer them on to someone, or also map it as they're going through chiropractic care and see how they're responding. But that functional work actually was done by the medical team. They were just doing it. So she'd report back to me. So a lot of that work I was the happy recipient of the information because of what other assessments that other people were doing at the same time. Yeah. So unfortunately, I can't take all the credit for that one.
That's nice to receive, right? It's always good. Let them do all the hard work.
That's another thing. We would so often take things like neurological exams and things like that. So often it's not that we don't want to or don't have the skill set to do them, but we think it's not a chiropractic thing. But they're actually still a good functional outcome. And it's like a cerebellar test, They're a good functional outcome that are a way of measuring how the nervous system's functioning. Marry it up with a really good detailed assessment of subluxation pre and post a program of care and as it's progressing through, and things like surface EMG, thermography, and measured range of motion. You're using tests that are medical in nature, I guess, to your advantage. And why not?
Yeah, that's awesome.
Some of them are crap, but, just don't use them.
Right. So just kind of looking at this, we had, did the posture, your subluxation examination. One thing that I just found fascinating about the case, and this is actually I definitely wanted to address, was so you took care of her for, it looks like it was 17 visits over the course of 10 weeks. For somebody post-stroke, I have to assume that there was some significant level of spinal degeneration. I don't know if you assessed, I don't remember assessing or seeing radiographs in there, but
no, I didn't write about those in there. I had seen imaging, and there wasn't an enormous amount of degeneration. The stroke was caused by, it was iatrogenic. She was getting properly prescribed medication, and overnight that happened.
Yeah, it was birth control, right?
Yeah, and so the result of it was tragic for her. But a main thing, and this is where, because I don't see a new patient thinking, oh, here comes a case study. I just remember, I think it was the third, maybe fourth visit, something like that. Because the very first time I used motion palpation and soft tissue palpation to determine what to adjust. Eventually, we got her lying down and comfortably lying down over the subsequent visits. But she'd lost complete power in her left arm, and it was about the third or fourth visit, I can't remember now. But she pushed herself up on the table, and I said, do you notice how you got up just then? And she didn't really consider it. I said, you just put all your body weight on your left arm. And she said, you know what? I'm even at home, I'm grabbing jars and opening them like this. I said, could you do that before? No, I haven't been able to do that since the stroke. I said, oh, that's interesting. And just let
that marinate.
And it was just a simple observation. And I think most of the time, well, not most of the time, but often in practice, we don't observe, our job is to observe, but we miss asking questions. We might observe things, but we don't ask the person you're seeing, you don't ask them the questions to help them understand that they, or see that change that they're experiencing. And I think we should spend a lot more time sitting back and observing, and then asking a question and letting the patient or practice member, let the light bulb go off.
Yeah, I definitely agree. Sometimes it's easier than other times. You just want to get your hands on them. You just know they're going to do so much better, and it's easy to just say, hey, this is what we're going to do, and just be very, very, very doctor focused and outgoing. And it's harder and takes more maturity to sit back and just kind of let the information come in and ask questions rather than delivering information. So that's definitely a skill that you've been in practice for a long time. It's something I could personally definitely work on.
Well, I think so often people try, you try to talk and deliver information in the hope that, I don't know why. Maybe it's to make yourself sound better, or in the hope that the patient doesn't say something to you that you find uncomfortable. But doing progress exams can sometimes be uncomfortable. And I know a lot of chiropractors that don't want to do them because they don't want to think or hear something that they perceive as negative. It's never negative, or might be a little bit negative, but it allows you to improve your practice at the very least.
100%.
It's a good thing.
I one time found myself, I was having a conversation with another doctor, and I was talking about how I was, in a consultation one time, or sometimes I'll be in a consultation, and this was like a big reflection for me because it just felt dirty when I said it. And I was like, you're in a consultation, they're telling you something, and you've already figured out what's wrong, and it's just like, all right, I'm just ready to go to the next thing. And it's like, man, that is so, and I said it, and I just felt like I needed a shower after that came out of my mouth, because it was like, that's not good. That's not good doctor bedside manner. It's not. And I've really reflected on that and gone back and been like, man, is this about me or is this about them? So I think that's a huge insight for a lot of people clinically. I love this. And one of the things that I've been focusing on a lot when I'm asking doctors, like clinically in these studies, is when you hear about this kind of history, like really significant neurological issues, I think the instinct in chiropractic is to say 3 times a week for 12 weeks, done. Right. And I feel like that's such an instinct for us to just say, hey, 3 times a week sounds great. We're going to do that for 4 weeks, for 8 weeks. And yet this is
simple.
Yeah. And it's like, this is significant change in less than a frequency of 2 times a week when you think about it. I mean, some were 2 times a week, some were 1. And I don't know why that is, if she didn't show up for appointments or if she was just holding early or whatever it could be. But that is just, to me, fascinating. After 4 visits, she was able to, like you said, grip and open up jars. And then after all that, significant changes, right? Significant functional improvements. She continued on care for 11 visits. And then she discontinued care following a meeting with her neurologist, her rehabilitation team, and her third-party payer. She stated that her neurologist gave her a directive to the rehabilitation team and third-party payer that she should not see a chiropractor, as they were concerned that chiropractic care increase the risk of a stroke. Does that still sting for you when that happens, or no?
No, I just, it is what it is, and people have certain perspectives, but if you stand back and look at it, the properly prescribed medication caused the stroke. The physical therapy team is actually, in fact, the reason she had the consultation with the neurologist was the physical therapy team had mismanaged her, so she'd had a further injury, and she was directed to continue with the mismanaging physical therapy team and to take the prescribed medication, but not to see the one thing that seemed to be actually offering her some help. So it's a shame, but hey, she still had that increased level of strength at that time. I don't know how long that, if it's continued or if it tapered off, but yeah, she had a positive experience, at least in the short term. So I don't know. I think you have to leave it at that. You just have to say next,
Right. Absolutely.
It's difficult sometimes it's difficult, but if you stress over it, then you got no mental space for the next people you'll see.
Yeah. Which kind of brings us into the topic that we really wanted to make sure we got to, right? Is like, what do we do? I mean, we can look at it, and obviously when you look at how many people perceive chiropractic and what they think and what we've done as a job of educating the public in terms of what it is and what we do, it's almost like you can be upset. You wish that they would ask more questions, but based on what they perceive that chiropractic is, allopathically, the allopathic model, it's almost like you can't really, not necessarily blame them, but we as a whole have done I think, poor job in really educating on safety, on efficacy, on what it is that we actually do. And one of the things that, we're told, and which we were talking about, is that subluxation-oriented chiropractors are a fringe group and that there's no evidence, right?
Yeah.
And that's not necessarily the case.
No, it's not. Well, I mean, let's take a step back. Take the thing like the stroke stuff, for example. You can't expect medics, as an example, to automatically think in the same way that we think. You could say vitalistic. In some respects, they still think vitalistically as well. But they think of things from a condition-based model, okay? So having case studies, and at that point of that case being published, there was 4 or 5, I think that was the 5th or 6th case study on that topic. And the only other thing, which is far more superior, is Kelly Holt from New Zealand and the crossover trial that they did. So more, a case study is great, reflects clinical practice, and it informs researchers and academics for further investigation. So in those condition-based things, there does need to be further investigation, and something that I think segues into what you were talking about next, the subluxation, is then demonstrating that chiropractic care, assessment and then correction of vertebral subluxation is the essence, that thing that we did as a profession that brought about those changes. So not trying to link it to any other thing, but, getting down to the nitty-gritty of subluxation. So that would be one thing in terms of other healthcare providers. In terms of our own profession, well, far out. I mean, the infighting is insane. And, you look at the entire spectrum, okay? There's people that want to practice a bit more condition-based. There's a massive chunk in the middle that are sort of a mishmash. And then there's so you could say vitalistic. Really, vitalism falls into the whole lot. So does mechanistic for that matter. Okay, there's people that come and see you and me for because they want to feel better in the low back or the neck or the front of their head or something like that. But we would see people and talk to them and discuss about expression of life. Now, those outcome measures we talked about before would be a simple way. You take the more mechanistic, condition-based chiropractor that still takes care of subluxation. If they add in a quality of life questionnaire, say a SF36, automatically they are assessing how that person feels about them and their own expression of life. So automatically they become the vitalistic, or of what have been referred to as the subluxation focused or the unorthodox. The most recent one is we're unorthodox. There's orthodox chiropractors. It's like a religion. Orthodox and unorthodox chiropractors. It's and somehow the unorthodox are the ones that prescribe to some traditions. But subluxation, we do get told a lot on probably social media and academics and researchers that are a tiny speck of the profession in reality in terms of volume. We get told that the subluxation focused chiropractors, we're a fringe group, and this almost charlatans and whatnot, and that there's no evidence for subluxation. So there's so many different ways that you can look at this. And anyone that's listening, I'd encourage to go to the Journal of Contemporary Chiropractic. I had a paper published earlier this year that can't even remember the name of it. It's the vertebral subluxation is core to the clinical practice of chiropractic, but there's a gap in the evidence. So what I did with this which is pertinent to what we're talking about now, is there's different ways to look at the argument for subluxation within the profession or not. So the scientists and academics will say there's no evidence for it. Well, that's actually not true at all. Or they will say the vitalistic, the unorthodox, the charlatan group that they think we are, this minority group, that that their understanding is subluxation is the cause of all disease, or 95% of disease, because Dee said that, and I think it was 1906 or something like that. Said it once, and they always come back to it. So if you're subluxation focused, you take care of subluxation to treat all disease. Now, that's actually a mechanistic and condition-based way of thinking. So that's not even congruent with how what the subluxation focus group would actually think. And these are the evidence-based group saying this. What they're not doing is looking at the 100 years of evidence in subluxation models and theories from that point on. I find it really, really bizarre that that group will talk about being evidence-informed and evidence-focused, yet when it suits them, exclude a century of evidence. It's just insane, right? So here's one way to look at it. How do chiropractors and chiropractic students think, and what's their understanding of chiropractic? Or first of all, what about organisations outside of chiropractic, like the World Health Organization? They define chiropractic as a whole host of things and then finish it with a particular focus on subluxation. So according to them, that is a focus of what we do. Whether the chiropractors like it or not, that is a focus of what we do. So then if you look at the evidence for how chiropractors practice, and there's a lot of evidence from around the world, Australia, North America, US and Canada, in the UK and New Zealand as well, that looks at how chiropractors think and practice. And the vast majority are focused on the assessment and correction of vertebral subluxation. Now, some of that majority would see people because they have low back pain, and they will assess and correct vertebral subluxation in the hope that the low back pain goes away, and it probably does because we do a good job there, okay? But the core is assessment and correction of vertebral subluxation, and this is 70, 80% of the profession. Then you look at students. Now, students, there's only 2 studies which have even bothered to ask students how they feel and what they think chiropractic's all about. There was one in North America and then one that covered Australia and New Zealand. And a majority, they were small majorities, but a majority nonetheless, and their wording was chiropractic is focused on the assessment and elimination of vertebral subluxation. It's like bloody Terminator stuff, right? We're eliminating it. I'm happy with a reduction, first of all.
Yeah.
But they look at, and these surveys were mostly the Australian students were in university-based non-subluxation focused colleges. And in the North American one, most of the students in the study were from colleges like LACC and Northwestern and places like that aren't traditionally subluxation focused. Yet these students, they understand that this is core to what we do. So this very small group that's suggesting we are fringe, you know, they're changing or trying to change the discourse of an entire profession based on not even acknowledging the research that they have themselves done, because most of it is done by several of the subluxation deniers. Okay, so that's one way to look at it. How do we practice? So if the colleges are inconsistent with how the majority of people practice, to me that's a massive problem, because you're pumping people out into a pool that they're unfamiliar with, perhaps. Most recently, if I can finish that little bit on this, most recently there was a paper that reviewed how chiropractors throughout Europe think and practice. And there were 5 groups. This is where the orthodox and unorthodox came from. And the unorthodox were us, subluxation focused, correction of subluxation to improve expression of life. Okay, easy things to assess, easy things to assess outcomes of as well. That was 20%. About 5% assessed subluxation to address visceral issues. You know, my God, we're told that chiropractic couldn't possibly ever help a visceral issue, but 5% do that. And then there was another 50-something% that solely managed subluxation because of musculoskeletal complaints. Okay, so it was 80% that manage subluxation. That is what they do. They correct or assess for and then bring about the correction of vertebral subluxation. Okay, so I think that's an important thing to understand. Most of us do that. It's just our intention around it, or our outcome of measure is different. For you and me, we would be asking questions about, okay, is life better for you now? We'd also ask questions about how you're feeling, but is life better for you now? Those 50-odd%, they just asked, how are you feeling? If all of a sudden they had asked, is life better, and done like a SF-36 or something like that, automatically that 50-odd% would happen to fall into the unorthodox group, because all of a sudden they were checking for and bringing about the correction of vertebral subluxation and then measuring expression of life. You know, it baffles me that there's such a fight in our profession over something that the majority of us do, yet this tiny group say it's fringe. How dare they say that most of us are fringe? That's just bizarre.
Yeah. It reminds me of, I was listening to an episode of On Purpose recently, probably a couple months ago, and they were talking about how the Canadian board is like really cracking down on mentioning any quality of life change outside of like back pain and neck pain and headaches. And they described, and this is just, I don't know if you got to listen to this episode. If you haven't, I'll find it. I'll send it to you. It's amazing. So the board describes the level of evidence that they require, right? In terms of the only thing you could have on your website, the level of evidence that they require. And they describe this level of evidence. Yet the level of evidence that they describe, we don't have that level of evidence for back pain or for sciatica. So somebody went and looked at all of the board members' websites and looked at their websites and saw what they had listed and showed how even the sciatica, all this and that, it doesn't adhere to this level of evidence that they require. It's like, I did an interview. I told you I did an interview with looking at the cervical lordosis and brain blood flow. I thought it was great. It was a great article. People get on there, oh, crap evidence for in a crap journal. It's like, what do you want? Like all we're doing is saying that addressing subluxation improves the quality of life. No, I don't know if your IBS is going to get better. It might. I don't know. Okay. Yeah. I just know that your life is going to be better. Your ability to adapt to and handle stress, which I can measure subjectively as well as objectively using things like thermal SEMG and heart rate variability. That stuff is most likely going to change when we correct this. And that's it. And I don't understand where there's this disconnect.
And will it change 1%, 99%? You don't know. But there is, if the only thing you're adding in is chiropractic, there is the possibility exists that chiropractic, when you've assessed and brought about the correction of a vertebral subluxation, does improve. We see it all the time. Yes, I mean, you just talk to chiropractors. They see it all the time. Whether they choose to suggest that they're part of our unorthodox group in the profession. I've got to stop saying that, I'm sure. But, whether they choose to think they're in that or not, they see it all the time. And I've sat down and talked to people, and they say, no, I'd only, I was, myself and Adrian Wenban were invited to speak at the WFC conference in 2013, I think it was. And it was meant to be a debate, really, between one was for open plan and one was for long-term care plans. And I was talking about long-term care plans. So I came armed with all this evidence to suggest that this was a good, even from things like headaches. And, the best evidence were you should see them for this time. But the other guy was saying, you should only ever schedule a visit and then another visit and then another visit. But the evidence would suggest you'd put them on a program of care, okay? But I talked to people after this because people came up to me and go, well, why would you put people on long-term care plans and things of this nature? And I said, well, do you have kids? And they said, yeah. I said, well, in practice, what do you do in practice? I only schedule people like this. I said, how often do you check your kids? I check them all the time. Do they have back pain? No, I just check them all the time. It's better for them. Why don't the patients that you see also deserve the same thing? Are your kids that special? And I'm sure your kids are really special to you. My kids are special to me. But why shouldn't someone else deserve or have the opportunity to have the same thing? And it's their choice, It's that individual's choice. In fact, around that, in my practice, and something I set up with the New Zealand College of Chiropractic at the time too, was on the health history form was, what are your goals in care? Very first thing they're asked, what are your goals in care? And basically it falls into short-term, medium-term and long-term and lifetime goals. And based on that, and I still do this today, based on that is how I present care plans to the people at a report of findings. So if they've only got short-term goals, I'll discuss with them. I'll say, look, these are some things, reasons other people see me, but your goal is this. So this is our program of care to here. And then at the progress, we'll discuss that further. But if someone wants to live a healthy lifestyle for the length of their life, I discuss that with them because already they've given me permission by ticking that. They've given permission to say, hey, this is something I'm interested in. So then I'll discuss that. We'll say, this is the first part of the care plan. Given that you've responded well, this is going to be the next part. Given that you respond well, this is the next part, and this is it ongoing and going and going, okay? And that's okay. They might not choose to take that on for the rest of their life. That's up to them. They might choose a different chiropractor as well. That's okay too. I just care that they're under chiropractic, okay? But I think giving people the choice is something that we should all do a better job of, and not dictate that people shouldn't have the choice because you only want to see them for short-term care. Let's get real.
Yeah, or vice versa, right?
Yeah, absolutely. Yeah. Restricting them from a lifetime of health and well-being just because you only want that for your kids.
Right. And I think there is a thing there. I mean, it's kind of looking at it as well. Now, I wouldn't change the care that I provide if somebody points to their shoulder and they want me to manipulate their shoulder, but their issues at the sacrum or they need correction at the atlas. I don't think it's responsible to just go moving that just because somebody asked. I think that's irresponsible if you don't have objective findings.
Absolutely. And that's quite okay to say, hey, that's not my area of expertise, but if this continues, I would recommend, I've got this physical therapist down the road or whoever it happens to be. This is what I do and this is why I do it, okay? And anyone who's listening will have seen wild changes beyond beyond what the person presented with. It happens all the time. I mean, I remember doing a study back in, it wasn't published that long ago, but we did it at the New Zealand College. I was interested in people's attitudes to spinal screenings, and from that we looked at, did people that came in from screenings, because they weren't coming in other than that was what brought them in, and there was about 100 people and just under 100 people in the study. We asked them, prior to starting chiropractic care, did you think chiropractic could benefit your chief complaint? And I think all of them, the chief complaint was a musculoskeletal complaint, whether it was neck pain or back pain or something like that. About 65, I think it was only 65% thought chiropractic would help. And chiropractic did help in, I think, 94% of them with their chief complaint. But on top of that, we asked them, did you have any positive change in any of these things, from energy, sleeping habits, bowel and bladder habits, or a whole host of things? And 90% of people reported changes or a perceived benefit in areas well beyond their primary reason for choosing to seek a chiropractor in the first place. And this was students providing the care. Okay, all subluxation-focused care. I think the coolest thing in that study, though, there was 2 of these people that there was no improvement in their musculoskeletal change, but there was dramatic improvement in other parts of their life, which I thought, great. That's perfect. I mean, I'm sure they wanted to feel good too, but their life was better.
Oh, yeah, at least, I mean, great. I love when life gets better. That's the one thing we do now, right? And that's the one thing that we do now. I think that, looking at it, we kind of educate. One of the things we educate people on is ability to adapt to and handle stress, right? And stress can be physical, can be chemical, it can be emotional. And when we look at it, when we correct subluxation, the only thing that we know is that ability is going to improve. And that can relate to so many areas of your life. I mean, ask a GI and say, does chronic stress, does that contribute to IBS? And they're going to say, yeah, we know that for a fact, right? And not saying, once again, that adjustment is going to improve the IBS, but I know that if your body's going to adapt to and handle stress better, your life's going to be better. And whatever that means under that umbrella, I'm super excited to find out. And
we have technology to measure it, both subjective measures like a quality of, take the SF36, or there's a shorter version, the 12, and things like HRV. These things are readily available for us to use in practice, and it does measure how the person is responding to the life they live. It's widely used. It's so bizarre to me that things that are so widely used in other healthcare professions, all of a sudden, sometimes when we start using them, it's perceived as a negative thing. And I just don't understand that. Why is it okay, especially for the people that so desperately want to be medical doctors? We use something that might be seen as a medical thing, and then all of a sudden they're up in arms that we use that. Well, why? You're so desperate to be them. You use it. Makes sense? Doesn't make sense. But
Makes perfect sense. Makes perfect sense. So I definitely wanted to just kind of move in and direct in, and I know, and I want to thank you so much for taking the time to speak with me. Yeah. You've been in this game, in the research game, like you reference things. I read a lot. I'm pretty up on anything that's been published in the last 5-6 years, but you just reference things and peoples and studies and just having this knowledge for just like being in it for so long. I would just kind of want to get your perspective in terms of where you think that this fringe group, subluxation focused chiropractic, what direction you think our research and technology is going to go, what direction we should go, what you want to see in the future, what you think we will, anything among like what direction you think we're headed. I'd love to just hear your insight on.
Okay, well, I think we should stop the infighting to begin with. Where the other end of the spectrum throws us a bone and we're terrible. But I think we could have a lot of really great conversations throughout the spectrum of chiropractic and really engage that middle major majority that appear to be, for the most part, they do assess for and bring about the correction of vertebral subluxation for whatever reason.
Even if they don't want to use the word, right?
Yeah. Oh God. Yeah. Don't even get me started. There's a paper back in '97 where chiropractors in Australia were asked what are their common indicators for subluxation that they use. So there were common indicators, and by the way, you can assess for reliably a subluxation. I'll talk a bit in a second, but I was privileged to be in a paper about that. But I think in terms of evidence, the Australian Spinal Research Foundation and the Foundation for Vertebral Subluxation both have research agendas out at the moment that a key thing that's consistent in both is reliability and validity of finding a subluxation. Okay, what does these indicators that we use, what does it really mean? And I think that needs to be anyone that says there's no evidence for it is throwing the baby out with the bathwater. Okay, there is evidence for it, but we do have a lot more work to do. And I know Australian Spinal Research Foundation has certainly funded some papers on that, and the Foundation for Vertebral Subluxation, I believe, have too. So that is a really important direction. And then the moving on from that is, we do have a good foundation of what happens when an adjustment is made, but without that lower foundation of the reliability and validity of assessing for subluxation, you see so many studies where it's like, okay, after spinal manipulation, this was the result. No indicators as to why the hell they manipulated whatsoever. Oh, it was just L3. L3 was we flipped a coin and we chose that. We need to get a lot better at, okay, this is what we address. This is the indicators that we've reliably used to do it. Find out more about the validity, and then that supports this, righto, this is what happens when we make that adjustment. How many people actually are subluxated out there, and what are the global effects of when people are under regular chiropractic care? What are the effects for humanity? Okay, and I think that is the direction we need to go, but we just need to slow down, because I see things all the time where people are wanting to, I want to find out about that, but well, that's great, but there's a few little steps that we need to really iron out, at least get some decent information on before we go off into galactic chiropractic and find out about that out there. Okay, but I would encourage people to support those two organisations, actually, because we do need, the profession needs more evidence around the reliability and validity of subluxation, and then moving on from that. Okay.
Yeah.
I remembered what I was going to say before the study in 97. Most people, like overwhelmingly, it was 80-90% of them, subluxation was the preferred term for the entity. The author refused, even though that's what they wanted in the conclusion, still couldn't bring themselves to use the term.
Oh my gosh. I'm thinking of like 12 studies right now. I reviewed, I'm sure you read this. There was an article last year that was published. I think it was done at National or Texas Chiropractic College. I think it was Texas Chiropractic College. And they looked at autonomic responses or cardiovascular responses to spinal manipulation, to upper cervical spinal manipulation. And I was like, oh, so it's a randomized control trial. I'm fired up. I'm like, oh, great. Cardiovascular responses, good indication of the autonomic nervous system. They're like, it doesn't have, there's no indication of spinal manipulation has any control on this whatsoever. So I used to read that and I'm like, okay, so if it's research, if it's a randomized control trial, I just want to know, why is that the case? Because that is so against what I've seen clinically. That's against what I've personally seen, that I just want to understand what they came, and maybe I'm wrong, right? So I go read the methods. So the control group is a sham adjustment. The experimental groups are a left atlas manipulation and a right atlas manipulation.
At the same time, just bang.
Well, yeah, so they compared a control group to left and to right. So they had no analysis whatsoever to find out if the person in front of them, A, had an atlas subluxation. They didn't even assess for joint dysfunction. They just hit him on the left, took the blood pressure. Hit step down somebody else, hit him on the right, took the blood pressure. Of course you're not going to see change. If I hit you on the head with a shovel, your blood pressure is going to go up, right? Because you're in fight or flight. That's crazy. Through the roof. Yeah.
A study like that and credit to the people for wanting to do the study in the first place, but a study like that, like whether it's chiropractic or anything else, without a rhyme or reason for why you're going to do an intervention, it's just trauma. What the hell? What is the point of that?
Right.
And so we do need to be and that the paper in the Journal of Contemporary Chiropractic that that was published of mine earlier this year about the gap in the evidence is centered around that. And I was limited to the chiropractic journals and anything that was of a clinical nature. And the vast majority, for the vast majority, there was some form of assessment. Most of them were case studies, of course, but there was some form of assessment as to what it was why you would address the spine, why you would address the subluxation. Oftentimes it was just really joint dysfunction. It was, change in intersegmental range of motion and point tenderness. Fine. There's reliability studies to support those. but this is what we do to assess the person, but there was no follow-up. So after it, had that entity, those assessments, were they now negative? Were they not there any longer? And I think that's a massive gap for us as a profession. We talk about the assessment of and correction of vertebral subluxation, but we spend our time at best, not in the study that you talked about, but at best, we spend our time looking at, well, this is what we do to determine if the entity exists or not. But then you get studies like the one you're talking about where they don't do it. There's none of that. It's not measuring chiropractic, physical therapy, osteopathy, or anything. It's measuring chance. That it's the same as just allowing people to walk through a tunnel and every now and again someone coming out to the side with a broomstick and whacking them on the neck. That's what
I'm
it is.
sure some of them are going to have a change in blood pressure. I'm sure even some of them will, but it's not going to be reproducible because that's not chiropractic, right? And not even saying that blood pressure is the proper outcome because, it's just...
Well, it's not chiropractic. It's not anything. It's not even healthcare because in all healthcare you need some rationale for providing the service. In this case, the service is the adjustment or the manipulation. But if there's none of that, what was the point? And RCTs cost a lot.
I was like, how much money did we just throw away? That could have been used for I don't know, maybe figuring out if there was even I want to see a nervous system. I want to see a nervous system component, obviously, but just say literally, how much happier would you have been to say, well, we found out if the joint was stuck or not. And if it was stuck, we moved it. That would have been so much better than, we just slammed him on the neck with a shovel and saw what happened.
There's been similar ones in the past where it was something in the lumbars, L3 or L2, and it came down to a coin toss, which side. It's unbelievable. It's trauma.
Well, I appreciate people like you who are moving this in the right direction. There's been some cool research that's been coming out recently. You keep publishing crazy amounts. I don't even know when you sleep. Well, I guess you're on that, you're just on that New Zealand time. I don't know what you guys do over there.
Well, this is the future here, mate. This is what the future looks like. I'm already in Tuesday afternoon.
It's going to be good weather tomorrow. It's going to be good weather. Yeah, it's 10 o'clock here. So yeah, I'm just going to go ahead. I know you got stuff to do. I want to thank you so much for jumping on with me today. I brought a lot of value and I'm excited to take this and go through it and take notes on it again. Any parting words of wisdom, how anybody can contact you, any call to action you want to give, take a couple minutes. It's your time.
Oh, thank you. Well, thank you for having me. I really appreciate that. I think calls to action, I would encourage any of the listeners to be supportive of research organisations that support chiropractic, and those for me are the Foundation for Vertebral Subluxation and the Australian Spinal Research Foundation. Give to both. And then supportive of the colleges that support chiropractic too. Now, all colleges, their goal is to graduate a chiropractor, but some come out with certain knowledge and some come out with less knowledge in that area. I think we need to nurture, there's some existing colleges that are great throughout the world, but we need to nurture more colleges that are going to deliver graduates that are the future of the profession, that bring that take the profession forward. And the Scotland College is one that aims to do that, okay? And so I'd encourage people, if you're interested in supporting a college outside of one that you might have graduated from, but those colleges, they have students coming in to fund them. To get other colleges off the ground, the profession needs to support. So I'd encourage you to look at the Scotland College of Chiropractic. We're well in the throes of developing that program. I'm heavily into developing the curriculum for that right now, actually. It looks awesome. So scotlandcollegechiro.co.uk. I'd encourage you guys to get on and look at that and offer your support if you can. Apart from that, be nice to them. There's chiropractors that are pretty antagonistic, and we come from all backgrounds and all flavours. Be nice to each other and sit down and have a reasonable conversation, because if you do, people may well see a different perspective. I'll leave us with one thing. I was previously a clinic director of the New Zealand College of Chiropractic, and the last clinic director meeting I had in the northern hemisphere in North America, I asked all the clinic directors around the room. I said, I'm sick of seeing you guys wanting to get more money for physical therapy and insurance and blah, blah, blah. Who here teaches that the body's self-healing and self-regulating? And they all put their hands up. Okay, so it's vitalistic, yeah. Who teaches here that the nervous system's central to the function of that individual? Everybody did. Who teaches that interference to the nervous system, whether it be for a musculoskeletal thing or something else, interference can affect the way that human is able to function, interference to the nervous system? They all agreed. I said, well, would it be okay if, and then I said, do we all feel that chiropractors, given our specific and unique training, are the best people to serve dealing with that interference at the spinal level? Yeah, they all agreed. Okay. Could we all agree to call that thing that we might deal with then a vertebral subluxation? Seeing we agree with all the past stuff, and everybody but one said, yeah, we could do that. I'm not too sure if they do, if it changed them. But, having a conversation like that and saying, this is how we think. Back to that original case study, the stroke one, doing a thorough exam to make sure you're providing specific and safe care. Some people down the other end of the spectrum think chiropractors like us that are the subluxation focus group don't do any assessment whatsoever. We lay them down, rack them and crack them and hope for the best. That's all we do. I don't know a single chiropractor that's subluxation focused that does that. I know a couple that aren't, that do that, okay? But I don't know a single one within our camp that doesn't take pride in doing a really thorough assessment. And I'm sure you guys have all heard someone's come into you and said, I've never had such a thorough assessment. It took you 15 minutes. But I've never had such a thorough assessment from one of my doctors before in my life. And I thought, keep doing that. Keep punching above your weight, raising the bar. Be nice and polite to the others so they can gain your perspective. And, support those organisations that are supportive of the profession you want to see into the future. Because it's not about just now. It's about the future. And we need to think long and hard for what will be chiropractic in 50, 60, 70, 80 years' time.
Wow.
Over now.
Well, thank you. Thank you so much for spending this time with us and our listeners. Thank you guys. For those of you guys who listen, this is another episode of the Chiropractic Research Breakdown. Something cool we do is this article, the case study that we actually talked about on hemorrhagic stroke. We have an article we're handing out in our office called The Real Story Behind Chiropractic and Strokes. And it just breaks this down. It's patient education, and just basically that, a thorough evaluation is going to improve quality of life regardless of the symptom. So you guys can check out something like that. Go to chiroedgemedia.com. Anyway, thank you guys so much. I love you. Go slay those subluxations.